Please join me in giving Joan Tammany a warm Pachyderm Club welcome.
Well, thank you for having me today. It's always a pleasure to talk about mental health services in our community, and specifically what we're doing at COMCARE. I'm going to talk a little bit about who we are, and then talk about our funding, and then talk about some of the accomplishments and activities going on in our community. So just kind of a broad breadth of information. I think the most important message to communicate is how prevalent mental health issues are in our community. So the national statistic is it's an average of 1 in 4 individuals will experience a mental health issue at some point in their life serious enough to impair their daily functioning and cause stress for them. So if you think about it, in the room there's probably about 60 people. Many of you in here will know somebody with a mental health issue, and it's broader than just depression and anxiety. It goes much deeper for people with thought disorders and other type of conditions that are lifetime and enduring. And I'm going to talk about that when I talk about our programs. But I also want to share the statistics around suicide, because this is an area of emphasis for all of us in our community, and it's not just a professional responsibility, but nationally we have over 100,000 people taking their own lives on an annual basis, and it's estimated that for every person who takes their life, 115 people will be impacted by that loss. So if you push that number out, we have 1 million people impacted by just suicide in our country annually. But even more staggering, in Wichita, in the last year, not this current year, we had over 100 deaths by suicide, which equates out to about 1 death every 4 days in our community. So if I could just deliver any message is, it's really important that if you see somebody struggling, to offer to get them connected to somebody that can assist them, or don't hesitate to ask if they're suicidal. If you ask, people will often share that they are, or give you indications that they're thinking of harming themselves. So we can change this course and trajectory in our community, but it's going to take everybody. With that, I'm going to talk about COMCARE. So COMCARE is a licensed community mental health center, and we're also a certified addiction provider agency, and both of these are defined in Kansas statute, and the pieces that are in statute talk about our governance, and it also talks about what services we're obligated to deliver under these contracts, and also then what we have to do in terms of documentation, outreach, marketing, education, and all of that stuff. So we have a lot of obligations to meet under our statutes for both those places. So we are one of 2 community mental health centers in the state of Kansas. There's 26. 2 of us are governed by county board of county commissioners, and that gives us the unique opportunity to be part of a larger system or a larger enterprise. But then, as a result of us having the Board of County Commissions as our governance body, we also have a mental health advisory board, and we have a 15-member advisory board. 3 members are appointed by each of the 5 commissioners in our community. And I know I saw Alta here earlier, and she was part of our advisory board for a while. And now Dalton has just been appointed by one of the commissioners. So we thank you for your service to us and for supporting our efforts in our community. So the board, the governance for the community mental health centers was established in 1962. So we've been around a long time, and in a few more years we'll be celebrating 60. So we're part of a larger system of care. So we're part of the county, but we're also part of the community mental health center system of care in the state of Kansas. I mentioned that there's 26 CMHCs. I'm going to call them CMHCs going forward. We're the largest. We have the smallest catchment area. I'm not in terms of size, and when you look at a map, because some of the CMHCs in the frontier have 26 counties, but we are population dense, so we have the largest county we're serving. We have the largest Medicaid population in the state of Kansas as well, so we have a lot of need in our community. So the Association of Community Mental Health Centers is an organization founded by the Community Mental Health Center's executive directors. They act on our behalf on legislative policy issues in the State House. They do a lot of building of our curriculum for our annual conferences and training that the system of care needs for our providers. So a nice piece of who we are. But then we're also part of this whole network of COMCARE. So we have 3 managed care companies that work with us with regard to mental health issues, and one with substance abuse. Aetna, who unfortunately has been in the news recently, Sunflower State, and then Optum United, and then Beacon is the managed care entity through COMCARE that does the substance abuse service authorization in our community. So we're a piece of a lot of different organizational structures, all of which have expectations around what we do, how we do it, how we bill for it, how we document it, how we have to be audited and licensed. So we're a heavily regulated entity in the state of Kansas. So I want to talk a bit about mental health reform, and I think I heard that there were several legislators in here and probably know the history, but prior to 1990, community mental health centers were pretty small. We had some clinicians who did intakes, you did some individual therapy, we might have had an after-hour phone call, but we didn't deliver a lot of community-based services. And does anybody know why? What was going on prior to 1990? Yeah, they were all housed in state facilities, and finally, the country started recognizing that people with mental illness deserve to have rich and rewarding lives just like every one of us in the room. And so there was a push to move people from state hospitals back to the community where they can have family support, friend support, and have some purpose and meaning in their lives. So they deinstitutionalized in the 90s. And when we deinstitutionalized, they took the dollars that were attributed to housing people in these state facilities, and they said, we're going to move that to the communities. And do you think that held tight for very long? No, the funding shifted. So we were well funded to grow our programs and try to meet the needs of the communities, and it was a nice time of growth and energy and creativity. And then the state had some financial issues, and they started shifting the dollars that were dedicated to mental health to other needs. And we all understand competing needs, but we have battled since that transition to present just to get back to our 2006 dollars in terms of our contract amounts. So I share that just so you're aware. Mental health is the most underfunded specialty health care around the state and nationally as well, although some states are doing a little better. So the philosophy around funding changes occurred, and now we focus our efforts on expanding where our money comes from and how we spend that money. But it does limit some of our ability to do some more creative programming just because we just don't have that excessive resource. So we focus on strengths. When in the old days when people were hospitalized, the emphasis was on their deficits. And I don't know about you, but I know what my deficits are, and I don't need somebody to remind me of those all the time. Does anybody in here? No. People do much better when they get to use what they do well and grow those strengths so that they become more capable of managing their lives independently than relying on services to do all of that for them. And then we do have a philosophy of recovery. We believe people can and do recover. People may have backslides if they have a chronic mental health condition, and they may never relieve themselves of all their symptoms, but they can recover and live meaningful and purposeful lives. So everybody always wonders, how are we funded? And we're the largest community mental health center in the state, so everybody always thinks we have all this wealth in our pockets. But if you could see by this slide, the reality is most of the revenue that COMCARE pays salaries and builds our infrastructure is based on the services we deliver. So we get reimbursed through Medicaid and other places like managed care companies, commercial insurance. That's 62 and almost 0.5% of our budget. We do get some state contract dollars. We dedicate those to the uninsured and the underinsured. In our community, that population continues to grow. We do get a small amount of community funds, federal funds, and then we get some support from the county, just under 10%. And then we have fee-for-service for people that don't have income and have some ability to pay. So I just share that just in context because people always wonder, how are we supported? So talking about COMCARE in a snapshot, we see 15 to 16,000 unique individuals each year. That's a lot when you think of the fact that we serve people with mental health conditions. That's a large percentage of our population who struggle and need pretty intensive supports. We serve them at different levels. We may just see somebody once at our crisis program, or we may see somebody every week for many weeks or many months or continuously based on the needs they have. And then here's another one of those staggering statistics. So we manage a crisis line, a 24/7 crisis line, and we also serve as one of the national suicide hotlines. We receive over 65,000 calls from people or family members struggling with themselves having a mental health condition or somebody else having a psychiatric crisis. So there's need, and we're there and try to be the support that people need. I think the other thing that I want to communicate is COMCARE is unique in that we're not a private practice clinic. So our population isn't coming and going to hopefully have their situation resolved in quick order. We have a pretty unique situation with our population is in that they're high need and they're highly complex. So they don't just have a mental health condition, they probably have a substance abuse disorder, and they probably have multiple medical conditions going on at the same time. So it's a complex population with complex needs, and it requires us to partner with a lot of other agencies in the community. So I'm just going to talk through each of our programs. This is our administrative services and medical records. We are in the Ronald Reagan building at 3rd Street. This is our infrastructure and our leadership, and then our billing staff are located here. We don't deliver services out of this building. But I'm going to talk about the different programs. This is our Community Crisis Center, and your Vice President just shared that we're available to give you a tour this afternoon at 2:30. I hope people take advantage of that, but we're located on Main Street, and you can see by our statistics, we served over 6,000 people last year through that crisis program, and again, over 60,000 calls. Co-located with us at the Community Crisis Center is the Substance Abuse Center of Kansas. We thought it was better to partner with somebody than try to deliver both the mental health and substance abuse services, and so SAC is in our building with us. They do sobering and social detox, and they have a high volume of people who are being served. Those numbers are on your handouts. And then we in this building have a large number of master level clinicians who can do assessment and screening, referral, and or brief therapy with patients, and then a large number of case managers because our observation beds are here. So somebody needing psychiatric crisis support for 23 or less hours can stay with us at this facility and get that support before they go back home. I put this one next. This is our offender assessment program. This is one of those programs that is fully funded by the county because it was part of an effort to reduce the volume of people with mental illness in the detention center. So this is one of those diversion programs. So we have folks that work with persons who have nuisance type crimes in the community based on their mental health conditions, so they don't wind up spending 6 months in the detention center. We get them treatment and get them back to a normal life. But also housed here are our stabilization beds, which is a part of our crisis continuum. So these are folks that need more than 23 hours of support, but less than 3 days of support. So we have beds here, and we provide a therapeutic environment for them. And then we also have what we call Morris Place, and these are longer term beds. So some people just really don't function very well on their own, and they need supports, and they could stay with us longer. All of these crisis services are designed to reduce the number of people going from our community to a state hospital in Osawatomie. We believe people get better closer to home, and we believe we can provide better care in the services. So we keep pushing the envelope and trying to get more funding to increase the services we can deliver. Our next hope for funding is to support medical detox so they don't have to go to the hospital for that detox service. So I'm going to have a couple slides that have the same building on it, but I want to talk about the different services. So we have a same-day access program, and this is where adults can come and get screened and referred for services either at COMCARE or if they're better suited for another agency in the community. And you can see there we did almost 2,800 screens and assessments last year in that program. We have an addiction treatment program where we deliver services to adults who have a substance abuse issue. We're unique in the community in that we have psychiatrists, so we get a lot of the folks with both a mental health and a substance use issue, and then have that medical support for them as well. And then we have our rehab services. So our rehab services is called Community Support Services, and I'm sure people in here have family or friends, but this is for the folks that have the chronic and persistent mental illness. So they have a lifetime illness. It's usually psychosis or a thought disorder or a significant mood disorder like bipolar, and they really struggle to keep those symptoms under control. We provide the rehab services to give them coping skills and help them manage their symptoms, and really do those wraparound supports for those adults through this program. Our adult medical services, we consolidated all of our medical professionals into one location. We have psychiatrists and advanced nurse practitioners who prescribe medication and monitor folks. We have individuals who are on long-acting injectables, so there's some disorders that are best treated with a long-standing injection. It also provides for better compliance with medication because they don't have to remember to take it every day. We just need to get them in on a routine basis to keep those shots going. Good success on those. The earlier they start those, the better success they have long term. So also located in this building is a program called Health Links, which does care coordination. We know if you improve one's physical health, you improve one's mental health. And so we focus on making sure they get their preventive screenings for diabetes, hypertension, all those chronic health conditions that our population has. And an interesting statistic is that it's known nationally that people with a severe and persistent mental illness die at approximately 25 years earlier than people who don't have that. But do you think they're dying of their mental illness? No, they're dying because they don't do well in traditional medical settings, and it's so a 15-minute appointment for somebody with a thought disorder is like a blip on our radar. They don't get the ability to express what their needs are, so these care coordinators help communicate that and work with the physicians so their needs get met. And then you'll see we have a Grace Med COMCARE sign on that building. We have entered into, it's a few years old now, a collaboration with Grace Med where they have one of their clinics within our facility, so that our doctors can communicate back and forth, but more importantly that if it's in our building, our patient may actually access medical care more quickly or more timely than if they had to go out and find that building somewhere else. And then we have a clinician embedded in there to help them navigate that system as well. So our children's services, much like our adult rehab services, these are for kids with severe and emotional disturbances. These are individuals who really struggle in multiple domains of their life. They struggle in school, they may struggle at home, they may struggle in the community. Some of them may develop long-term adult mental health conditions. Many of them won't, but it's our way of trying to provide early intervention to individuals under the age of 18 who are really struggling to live a normal life because their mental health condition is impacting that. And where do we most often see that? In school and at home. So we now also have school-based services in order to interact with youth in their natural setting during the day, and it's really proving extremely successful. But we have medical staff who specialize in children's medications and treatment there as well. And then we also have a homeless outreach program, and we co-locate at Open Door downtown. This was an opportunity to partner when they built this facility, and our goal is to outreach to people who may be living under bridges or going in and out of the shelters who are doing that because their mental health condition is impairing their ability to sustain housing long term. So we do a lot of work around permanent housing through this program. So we're much more than just a mental health facility. We're trying to provide the natural supports for people who struggle. And then in 2016, we formed COMCARE Community Partners, and this is our nonprofit fundraising educational enrichment piece of our organization. The employee that we hired through COMCARE Community Partners just recently rolled in under COMCARE because the separation wasn't benefiting us, it wasn't hurting us, but now we have more opportunity to collaborate more closely. Okay, so I don't have a clock, so I'm hoping I'm talking on time. But I want to talk about some of our accomplishments, both for COMCARE and for our community, that have really enhanced the visibility of mental health services in our community. So I don't know, just by raise of hand, do people know about the school mental health pilot program? He's clapping over there. So not very many people. So in the legislative session, there was acknowledgement that kids are really struggling and families are struggling and kids are in school, and it would be better to treat children in their school setting so you don't have to go to additional appointments after work. And they funded a mental health pilot, and it was designed for six areas of the state, 3 urban areas and 3 rural areas, and it was to be a partnership between the community mental health centers and then a district in the community. And Sedgwick County, or at least Wichita, USD 259 and COMCARE are one of those lead partners in that, and so we worked with the leadership at 259, and they designated 22 schools for us to be in, and those schools were designed around the highest number of suicide alerts and stuff that they worked with, or a lower income where parents were struggling to get their children to school. But anyway, we learned very quickly into that, that boy, our youth are really stressed out. They have a lot going on, and there's a lot of anxiety and a lot of depression. And what does that translate to in school? Well, is they can't concentrate in the classroom. If they get too anxious, they tend to disrupt the classroom. And typically, in a school setting, the only response they have is to dismiss them or expel them for a period of time. When we went in with the hope of reducing the number of acting out incidences in the school, and then increasing school attendance, and then increasing school performance. And shockingly, not shockingly to us as mental health providers, but I think statistically for people who didn't know how this was going to go, in our community alone, we have a 66 or higher % improvement in all 3 of those areas. Those 800 youth benefited from having mental health services available to them in the school. And the reason it was a benefit is the school counselors focus on what's on their individual academic plan, where we can come in and actually do mental health treatment. They don't have that luxury because their funding for their school social workers is dedicated to a specific thing. And then we brought in the expertise, and collectively those teams have really been phenomenal. And we're going to move into year 2 next week. And we're hoping next week at the Kansas State School Board meeting that they vote in an expansion of that pilot program to include many other communities and give them the same opportunity that we've experienced. So we're really proud of that collaboration, because you talk about an academic setting and you talk about a mental health center, part of a governmental entities, those are huge systems that have to learn to work with each other. And we all have different expectations and different rules, but it's worked out really well. And then we have this collaboration going on called the Mental Health and Substance Abuse Coalition, I believe Todd Johnson talked about this earlier this summer. A group of us have been meeting for years, and we started out several years ago. It was the sheriff's office, it was Via Christi, it was COMCARE, and somewhere along in there, WPD joined. But we were struggling with each other, and we were pointing fingers at each other and saying, you need to fix that, and you need to fix that, and you need to fix this, and you need to take this part, we shouldn't be doing this. And we recognized that we were working with the same population, and after all that storming, we actually realized that we can work more cohesively together, and have been doing so ever since. And then we've been having larger and larger meetings, and as recent as, I think it was earlier this year, we decided let's make this official and form an actual coalition around this issue and start bringing in other members of the community, because the reality is COMCARE can't do all the mental health services in the community. The detention center can't be the only place where people get taken to if they get picked up because their substance use or their mental health condition led them to engage in criminal activity. And so we've just recently started a strategic planning process through this this coalition with the hope of having that strategic plan defined by, mid to late fall. Just finished up some forums and feedback sessions, and anxious to hear what that feedback was. We should hear it in the next few weeks. But at the same time, looking at what is our capacity as a community. And we had an outside entity through a grant who evaluated the reality is we don't have enough providers. In 10 years, we're just not going to have enough providers at this rate to deliver all the mental health services needed in our community based on growth in the last few years. So we're going to continue to keep you posted on those activities, and hopefully many of you have engaged in some of those feedback sessions, but it's pretty exciting. And so COMCARE has a behavioral health community collaborator that helps with those processes. Her position is funded. This is where private partners work out really well. The Sunflower Foundation out of Topeka funded this position in full. And then we have a substance abuse coordinator through the sheriff office that's partially funded through the Crime Commission and partially funded by COMCARE. So we're getting more buy-in and we're getting this issue built. But at the same time, you see on the news every night some sort of story about something going on with somebody who supposedly has a mental health condition. Not all mental health conditions are the same. Just, news is a piece of the story and not the whole picture. But we have a lot going on. And then we also have a high utilizer study where Via Christi, the Substance Abuse Center of Kansas, and COMCARE, over 2 years, because of the complications of sharing patient-specific information with one another, finally got through all of our review boards, and we were able to look at each of our top 200 individuals. So a pool of 516 individuals. We looked at how many of those overlapped each other's services and what they were costing us. And now we're at the point where we've identified that population, and now what do we do different with them? Because clearly they're not responding to our typical approach of we're here if you want us. We need to find ways to creatively engage them differently and treat them, because between that population, I think we spent $56 million on them over 4 years. Lot of money on a small percent of individuals, and individuals with high needs. But we need to treat them in the community and not in the jail and not in the emergency rooms or intensive care units at our hospitals. So I'm really proud of our community. There's a lot of conversations going around the issues of mental health and substance abuse. We're blessed to be at the table for all of those as the mental health center. But there's still opportunity for people to get engaged and get involved, because it's going to take some really innovative and unique approaches to move this forward to where we want to go. And then I just want to share that we do cost avoidance studies. WSU does them on our behalf to see what the Community Crisis Center is saving our community and the state. And we've done that several times, and the new one should come out later this fall. But if you see, conservatively, it's saving $9 to $12 million. And the cost avoidance is based on how much police officer time are we saving by not having to get them to the emergency room and then them sit with them till they're admitted? How much money are we saving by not having to transport them to Osawatomie State Hospital? How many state hospital bed days are we saving, and what is the cost of that? And if we keep them out of the jail, what are we saving each year? So 9 to 12 million with a program conceptualized as a innovative tool to reduce hospitalizations and detention center stays is well worth its money, as far as I can see. So then we also have, we also do community education and outreach all the time. We do mental health first aid and what we call assist training. So if anybody in here knows or wants to participate in a training that teaches you how to recognize and talk to somebody with a mental health issue, we do those courses throughout the community all the time and are willing to do those for special groups or just let you know when those are occurring. And then even further beyond that is, so mental health first aid is kind of like Red Cross first aid, get everybody prepared for the basic intervention if you encounter somebody in an emergency. That's what mental health first aid is for mental health issues. Assist training teaches people how to intervene. So if people have basic mental health first aid training, they can advance to the next training and actually figure out, how do I talk to the person when I need to get them to go to a crisis program, or how do I encourage somebody or engage them in a service in the community. So really worthwhile programs, and just want you to be aware of that. Via Christi just completed a multi-million-dollar renovation to their facility at St. Joe, where they consolidated all their behavioral health services into one location, and they called that Project Renewal. It's nice to have all those services in one place. And then KBC just came to town. It's a children's acute care hospital, and that provides COMCARE the opportunity to partner differently and locally. We partner with them in Hayes and Olathe, but it's nice to keep our kids in our community, and how much nicer that is for parents who have to transport their children out of our area and then leave them there and trust that they're going to do okay and be okay. We're doing that locally now. And then just recently, if anybody's seen on the news, the city of Wichita, several departments, and Sedgwick County, several departments have engaged in an integrated care team. And what this is designed to do, it's modeled after a program in Colorado Springs and Tulsa, but it's designed to reduce the number of 911 calls that require a specialty team and a specialty vehicle, which is expensive to run, and target those that have behavioral health needs to this integrated care team, where we have a social worker, not a social worker, but a clinician on that team, along with a paramedic who could do medical screening and law enforcement in the event there needs to be some legal interface. That team started rolling on the 30th. We'll roll until October 31st. We run Tuesday through Friday evenings from 2 to midnight. It is designed as a proof of concept program, with all of us knowing it's going to be successful, and then funded continuously thereafter. It's been pretty exciting to see the results. Our goal is to always at least treat 50% of people in place, where we don't have to take them to the crisis center, the hospital, or the detention center, and we're above that statistic. And then we've been able to direct people and give them resources, so the number of people going to those higher levels of care or needing those higher need vehicles in our community are being met in a different way. So pretty exciting, and we're happy to be there. And then we just got funded with 6 new positions for the next year's budget for the county, and part of those positions are going to enhancing the number of opportunities we have to send our staff into the field to see people rather than everybody having to come to the crisis center. So mobile service enhancements. There was the ICT one. That's the integrated care team, kind of capitalizing on the ICT, but it actually stands for integrated care team. And then the coalition, which Todd has spoken to previously, we're really proud of where this is going, and look forward to seeing what we can achieve as a community going forward. And then I just wanted to bring up a couple of challenges. I haven't seen John. Has he stood up? Am I running tight? Okay, good. Okay, so I want to talk a little bit about some of the challenges. State hospital beds are a premium. They have a lot of people who are there long-term, so the turnover isn't quick. And some people that may never discharge because they're in really a dire need for that level of care. And then several years ago in 2015, the state limited the number of people who can go to the state hospital because they had some certification problems. They couldn't sustain their certification with the feds. So it reduced the number of beds we have. But more importantly, it reduced the ability to send people who voluntarily wanted that level of care. So the only way people can get to the state hospital now is if we deem them in need of that level of care because they're a danger to self or danger to others. And again, that's where these community alternatives that I've talked about become really important, because we want people to stay locally when they can. We think they get better, but this level of care is necessary and needed from time to time. And then the criteria continues to change. So they used to be a state hospital, now they talk about being an acute care setting, which is a problem for us because we get people to Via Christi, which is an acute care setting, and then it's hard for us to get them to the state hospital because they consider themselves the same level of care. But technically, these are supposed to be intended for persons who need state hospitalization, which should be a higher level of care. And it just, all of it just puts pressure on our community. So we're promoting and working tirelessly talking with the legislature about, and the state officials about getting some of the state hospital beds dispersed across the state so that they can be local, where people can have better treatment options, better transitions from that level of care back to their community. We believe that if their families or friends or other loved ones can be involved, they have better opportunity for a smoother transition as well. I mean, if you think of somebody who goes to a state hospital, sometimes they lose their housing while they're there because they're not living in the place. It's hard to get housing when you have a severe and persistent mental illness and may have disrupted in those places and have a difficult time being accepted into some of the other facilities or for housing around town. But they've given up their pets, they've lost some of their possessions if they left them with somebody. It's horrible when people have to travel that far to get care. If we can keep them local, we have more options for them. They published a request for proposal to the state several months ago, and no action on that, which I think is appropriate because of the change in leadership up there and give them the opportunity to help find solutions. Our capacity at the crisis center, we've reached it. We are seeing the number of people we can see each night, each day, and hopefully over time we get the opportunity to expand that. And then we continue to have workforce shortages. I know many of you probably work in industries where it's hard to get people because there's more openings than there are people in our community. When you have to have a master's degree in a specialty field or a bachelor's degree in a specialty field, that pool gets even more limited. So we continually challenge to make sure that we have the right people and enough people to do the work we do. Okay, so I'm just going to share that we know Medicaid enhancement rates for us would be particularly beneficial. We get paid very low. Oh, thank you. You let me know I'm almost done. I appreciate that. So we get like $16 for a medication visit. $16 doesn't pay the salary for a psychiatrist. So we're fighting for increased rates for services that we deliver. We're also pushing the state to continue to look at reestablishing the funds that were promised with the mental health reform I spoke to earlier. We're treating them in the community. Those dollars should go to the community. And we continue to fight nationally for equal status to community. The healthcare centers like the FQHCs here in town, Grace Med, Hunter Health, et cetera. So the why is important. 1 in 4. We need to help those that need help. I mean, they deserve to have good services, quality services, and they deserve to live meaningful lives, and that's why we're here. So with that, I appreciate the opportunity. Hi, Alta.
Appreciate it. Yes. As always, we're going to take questions. We have a few minutes here. Our Pachyderm members will be allowed to ask those questions first. Okay?
What kind of a relationship is there between you and some of these substance abuse programs like the 12-step program or Celebrate Recovery, some of those things? Do you guys have a relationship with them?
Well, we don't have a formal relationship, but we encourage our patients to engage in any self-support group that meets their needs. So if somebody likes the values of the 12-step programs, we encourage that. If they like alternate programs, there's the grid, there's the ones you mentioned. There's lots of different options. So we want people to get involved in those community groups that are going to meet their need, because some of them are pretty rule-bound around medications, which makes it unwelcoming if somebody's got a psychiatric medication. So there's other options for them. We work closely with most of the providers here in town, as well as the support groups.
I wanted to ask, I kind of have my own feel for the issue because of some stuff that happened in my family, but in your opinion, what percentage of those who have substance abuse problems, alcoholism, drug addiction, are actually people who have been failed or left out by the mental health system because they're trying to treat their bipolar, their schizophrenia, their PTSD, and they have not found the right type of treatment, and they're treating themselves, and that's why they have an abuse problem. And if we would try to combat the mental health issue, we might very well get them away from the substance issues.
Yeah, I think it's I think it's a mixed bag. I think there's a large percentage who do start self-medicating, and it's always tied around their shame and other issues that they have. And I think those folks do self-medicate, and then it's always the substance abuse is the first to treat because that's the most obvious symptom. That's why we do the co-occurring, and we need more providers doing the both the mental health and substance abuse tied together because 63% of our population have both.
I made a visit with a family member to your crisis center once. My son is a bit faster than me, was in track in high school, and ran away.
Oh, yes.
When I was trying to get him into a system. He hid out in a Red Cross ambulance across the street, close to the crisis center. He's been to Osawatomie 3 times, but he's now working a part-time job in another county, and I thank you folks for helping save his life.
Oh, thank you for that story.
Thank you very much for being here today. So if there's a moratorium at Osawatomie, where do you send them when they need inpatient care?
Well, we have a great partnership with Via Christi,
Okay.
and then we treat them in our crisis program. We use those 23-hour beds, those 72-hour beds, and our long-term beds.
Okay, and how many beds do we have, and how many would you like to have, and what do they cost?
Oh, yeah. I don't know the cost of a state hospital bed. We would like up to 30 state hospital beds locally, quite honestly. We think that would meet our need, but we would like to expand the range of services we can offer in our community, like the crisis center too, because those work.
Do you have transitional facilities for them, like if they've been homeless and they go inpatient and then get out, and you get them stabilized, how do you keep them?
Well, we continue to wrap services around it, but we try to find them permanent housing. We have housing specialists that try to find them an environment that they can sleep peacefully at night. You know, if people sleep, they tend to do better in the day and take their medications, but we try to wrap the supports around them once we find them housing.
Thank you.
The state is considering expanding Medicaid. Would that be helpful to you, and if so, how?
Yeah, it would be helpful. I know it helps some entities, but it would help community mental health centers because I think 40% of our population is uninsured or underinsured. This would give more people. I think where it benefits us the most, quite honestly, is people will pick up their medications. When people can't afford their medications, they make choices. Do I eat, do I sleep, or do I get my meds? And this will help people stay on their medications, but also give people more choice in where they can receive services. So we do support Medicaid expansion as a community mental health center.
You mentioned you recently launched the ICT-1 program with the big, bright red van.
Yes.
With it plastered on the side. I want to ask, are there certain uniforms that these people are going to be wearing when they're coming into people's homes? And are you concerned about a stigma that the neighbors are going to give to a family with mental health issues?
I would rather a red car come to their house than an ambulance or a police car with their lights flashing. It's red because that was what was available. There was no funding to start this. The city had a vehicle that was available and equipped for that need. Would we want a red vehicle ideally? No, but that was the option we had at the moment. I'm not too worried about stigma. You know, these are folks that are calling 911. It's going to be a vehicle with flashing lights or this vehicle. It's not people who are calling our crisis center and wanting us to come out in a more private manner. We'll do that in a vehicle. This is intended to respond to a 911 call. Can I just go back to your question on stigma? I think the fact that we don't talk about it enough or make it more of a public issue is more stigmatizing than trying to get resources to the population. So I get where you're coming from. I don't like a red vehicle either, but that's what we have. But I'd rather they get the right service at the right time than not get a service.
And there was no like van available, it didn't say ICT-1, and then you put it on the news. And so the neighbors across the street are going to talk about it in front of their children. Their children are going to go to school the next day and say, my dad said, you can fill in the blank.
They're going to say that if an ambulance shows up or
Maybe not, it could be a medical emergency.
I respect your opinion. I do. We've had those tough conversations as well. It's a tough issue.
Life is easier if you just let everybody know. Speaking from experience, there's no reason to cover it up. Mental illness is nothing to be ashamed of.
we look at mental illness as no different than a health condition. It's no different than somebody having diabetes.
You're never going to get to a cure.
Sorry about that.
Yes,
I didn't want to dismiss her concerns. I wanted her to know I heard that.
my granddaughter just finished the first stage of rehab on Wednesday. And that was a facility where she could not come out of.
Mm-hmm.
Now she's allowed to go out and then be back at a certain time. But I'm wondering, even though they're looking for housing and stuff for her, how long would it take for her to integrate and get her family back? She has 3 kids.
Oh, shoot. I couldn't even speculate on that because I don't know why maybe she had her children taken from her and how much involvement she's had with DCF and others. I can't respond to that, but it could take a long time.
Yeah, but if you complete the first stage, you would assume that they checked all of that stuff out.
Yeah.
And moved up to the second stage. So,
I'm hopeful it's not forever, but I think they're going to wait for her to demonstrate some long-term commitment to rehab.
I just want to thank you. I'm a school counselor, and I have called you numerous times, COMCARE. I am elementary
you're
counselor. 3 to 5 times a week, I typically do a suicide protocol for elementary, and people
Isn't
are
that
shocked
sad?
that these are elementary children, ages 4 up to 10 years old, and COMCARE responds. And what the protocol is, I send these children to COMCARE, and they have a walk-in clinic that the parents take them to. So I want to thank you very much for your service.
Well, I appreciate that, and I know we got off to a rocky start with that program, but it really has smoothed out and is going really well.
Well, it works for the kids, it works for the parents.
Appreciate
So
that. Thank you.
Thank you so much, Joe.